Okay, so welcome to session 3. I hope you can get up and grab a coffee quickly. We have 3 more fantastic talks. We're going to be talking about how can we develop useful QSP models in rare diseases. Our first speaker is from Stanford School of Medicine, Dr. Tina Hernandez-Boussard. Then we have from Denali Therapeutics, Dr. Kapil Gadkar. And then Dr. Gary Ahn from University of Vermont. And we're going to wrap up these 3 talks with our final discussion and question session with Dr. CJ Musante from Pfizer. So why don't we go ahead and get started? Dr. Hernandez-Boussard, are you ready?
Great. And so, hearing these other talks, I was, I'm hoping that this talk will still be relevant and applicable to everyone. I want to talk about some of the work we've done, just really thinking about the digital twin technology. And then how we can use this for, drug development for rare diseases and small population sizes. So as mentioned, my name is Tina Hernandez-Boussard. I'm a medical informatician at Stanford University. And so this is going to be some work that we've been thinking about a lot. We've done a lot of work in the cancer space, but we're also looking in other disease areas. So get started. Okay, so what I want to talk to you today about really is defining the digital twin. And I know we've heard in a lot of these previous talks about the digital twin, so I'll go quickly over this. But what I really want to talk to is where I see the real opportunities and challenges for other teams to start using the digital twin. So really, what is the digital twin? We see it all over the literature right now. Everyone's using different concepts or different definitions of the digital twin. So I just want to give a little bit of background on this, right? The digital twin is a virtual representation of a real world entity and processes that are synchronized for a specific frequency and fidelity, right? The digital twin uses real-time and historical data to understand a representation of the past state, the present state, but more importantly, to simulate predicted future states, which is what we saw in some of the talks just in the last session. And what's important is that the digital twin is motivated by outcomes, tailored to specific use cases, and powered by integration of data, built on data, and guided by domain knowledge. And so, excuse me, we see digital twin use cases in all different types of industry. We see it in manufacturing to simulate performance in real time, in transportation, in trains, planes, automobiles, etc. And more recently in life sciences to predict disease course or treatment effectiveness, right? And so what's important is we're seeing digital twins are starting to transform business and research by accelerating a more holistic understanding of an entire system, using the digital twin to really optimize decision-making and really for effective action evaluation. So there's a lot of opportunities to think about the digital twin use case in our small population sizes and rare diseases. So how is the digital twin different from just regular predictive modeling? So in general, traditional predictive medicine relies on a select individuals to develop general predictions, right? And these results may take time. They may be related to imprecise conditions, and the explorations are limited by the available physical models, samples, and data. And more importantly, what we've learned over the past couple of years is that generally the populations used to develop prediction models are often biased and non-representative of the population to which we're applying these models to. So there's a big opportunity to think about how can we improve our traditional predictive medicine and really precision medicine. And so in general predictive medicine, what we're doing is we're making these general predictions. So, 10 out of 100 patients have, this side effect of this drug. Well, that's great if I consider myself, as a 10 percentile, but often patients are like, well, what about me? What about, how does that really relate to me? And I think that's where the digital twin comes in. So we're seeing the digital twins approach being used across the life science spectrum, right? And what's important here are we're seeing advantages to really bring predictive analytics to the forefront of medicine, right? We're using the digital twin to anticipate and to prevent events before they occur. So you can see this opportunity for using the digital twin for clinical trials. We're using the digital twins approach to explore treatments for an individual. So we can we can look at the spectrum of treatment options for a patient and identify what might be the optimal treatment for an individual patient. We're using digital twins approach to pursue and refine hypotheses. You can think of a cohort of digital twins for a clinical trial to simulate response for a population of patients, and also to explore conditions and scenarios and really being able to iterate and integrate understandings and insights from the digital twin. So as I said, a lot of my work has been done in cancer patients. So I refer a lot to cancer patients, but this can be used in any population size. So let's think about the digital twin and how it gives us a holistic view of the patient. As I mentioned before, previous prediction models are really giving a generalized risk score for a group of individuals. And what we really want to do is we want to start generating these risk scores or these predictions for the individual patient. And what's unique about the digital twin is it provides a more holistic view of the patient. It provides it requires that we use multimodal data, right? So we're moving away from these silos of looking, only at molecular data or only at clinical data or only pathology data. And we're thinking about how can we pull all of these types of information together to generate a more holistic view of the patient. And so that includes really raw data generation. A big challenge is how we process and merge these data together and label them, how we extract features and then embed them in a representation. And so what we're really trying to do is simulate outcomes across treatments for an individual patient. So for example, I might have a patient and I want to say, okay, what happens to the tumor in this patient or the disease in this patient, whatever it is, if they have no treatment at all, right? That's my one scenario. I might then say, well, what happens if they get the standard of care, right? So this is the current treatment. I want to know where their outcome will be in the next 30 days, 1 year, 5 years, however you want to define that. But then unique to the digital twin is I can say, well, let me start simulating the outcome of this individual patient, this single patient across these different treatment options. So really we can identify, one, we promote shared decision-making because you can identify these different treatment options and talk about this with the patient. But also you can identify, what's the priority of the patient? Is it quality of life? Is it having symptom A versus symptom B? And by simulating these outcomes, we can really start to have that discussion. And so why are we hearing so much interest right now in the digital twin? And I think this is really because of the changing landscape of drug development. And, I don't need to say this to this population, but I'll just mention, in December 2022, the FDA amended one of their very old policies requiring animal testing for drugs, right? And so this opens new opportunities to think about how we can use different types of other alternatives for drug development, including computational modeling and how this fits into the digital twin. So I think the future is just starting to become developed, where we can start to think about how the digital twin really fits in this landscape of changing drug development opportunities. And so, the digital twin in drug development, I think the digital twin technology really has the potential to revolutionize the ways drugs are developed and tested, right? We can improve the efficiency and reduce the cost for drug development. And this is a paper that we published in Nature Medicine in 2021 that really walked through the way we picture or our ideas on how the digital twin works. This was particularly for cancer patients, but again, it can be applied to any disease. So really, we start with this accumulation of data, right? It's multimodal patient data integration. And these data vary across time scale and across size. We're talking from the molecular level all the way to the population level, understanding risk factors that the patient has, all the way down to, you know, the molecular level. We gather all of those pieces of data together, and then we start modeling the data, right? So not only are we modeling the trajectories, as we've seen in some of the talks today, of the patient, but we're also simulating outcomes based on this information. Now, ideally for the cancer patient, for the digital twin, that information has to make it to point of care. We have to be able to generate these predictions in a way that they can be integrated into the care platform, so that we can, as I mentioned, really improve the patient care decision making and the conversations between the clinician and patient. What is really important about the digital twin is it is a continuous learning cycle, right? So every time a patient comes in, we learn more, we continue to gather their data, and we can redevelop those simulation models. And so really the digital twin is really tailored models using multi-omic data, clinical data, environmental data, and social data to really evaluate and predict the most effective prevention and therapeutic plans for an individual. And so what opportunities does the digital twin provide for us? Well, it provides us to create more accurate and realistic disease models, right? If we have a virtual replica of the patient, we can simulate different treatment scenarios and predict outcomes of treatments to develop more effective treatment plans, but more importantly, for earlier detection of disease progression and adverse events. Right? And so by integrating data from a variety of sources, in multimodal data, as we keep talking about, right, we get a more comprehensive understanding of small populations, of rare diseases, and how we can be more accurate in modeling these types of populations. And by doing this, we can better predict drug efficacy, right? A digital twin will allow us or allows us to really test drugs, solutions, treatments before clinical trials, right? And in that way, we can use these digital twins to identify the most promising drug candidates, which can reduce the number of unsuccessful clinical trials. This, I believe, would really lead to faster drug development, right? By simulating the effect of a drug on a virtual model of a patient's disease, we can quickly test and optimize, you know, the candidates. And more importantly, the digital twin can be used for real-time monitoring. So you can see how important that would be in a clinical trial or even in clinical care, when we can more quickly identify adverse events, changes in disease, non-adherence to treatment, et cetera. So really powerful way to predict drug efficacy. As I mentioned, I think the digital twin could really help us think about how we can optimize clinical trials. So we can simulate trials and optimize trial design, right? You can test out these different options for trial design. At Stanford, we're creating a sandbox that's going to allow us to create these digital populations, so we can test out and play with these different trial designs to see which is going to be the most successful, which is going to be the most cost efficient. How can we reduce the number of patients in the actual clinical trial, but keep the safety and efficacy up to our standards? As I mentioned, in clinical trials, it can reduce the risk by identifying populations early, and we can really start developing these digital twin populations. So a lot of opportunity there. more importantly, as we heard from some of the talks earlier today, certainly from Susanna's talk, where she was talking about really we're trying to personalize medicine, right? So a digital twin allows us to develop these individual models based on the patient's genetic makeup, their lifestyle, their medical history, to really improve the efficacy of treatment for that individual patient, not for the general population, right? For that individual patient. And this is a great way to think about how we can advance personalized medicine. And I really believe that we can take personalized medicine beyond just the genome and the genetics of a patient to really start incorporating information on social history, on lifestyle, on past medical history, et cetera. And so I think we can't talk about the digital twin without talking about the equitable digital twin, right? Because what I see is the digital twin has really an opportunity, particularly in rare diseases and small populations, where we can increase the representation of the patient. We can simulate larger cohorts of particular patients and diseases of interest where we don't have enough patients to fill these populations, right? So provide a more accurate depiction of underrepresented populations. Personalization, right? Understanding the specific needs tailored to individual understanding specific needs and then developing interventions that are tailored to that patient's needs really gives us an opportunity to think more equitably about the treatments for a particular patient. I think there's an opportunity to think about accessibility to the digital twin, right? We can provide a virtual environment that's easily accessible and user-friendly to reduce barriers to entry and increase engagement across populations. And then also, as I mentioned, predictive analytics provides us an opportunity to identify potential problems and intervene early. As we've all heard, AI has been associated with biases and inequitable models. Well, if we have a digital twin that can identify these issues prior to implementation, we can identify these issues early. We can make modifications to that would allow us to better tailor treatments to more diverse populations. And so, oops, sorry. And so, there are so many challenges with developing the digital twin. And I really applaud the previous speakers who make it look so easy, but I can tell you it is not easy at all. It is a huge challenge to develop these digital twins. And what are the challenges? The challenges are the data, the modeling, high performance computing, clinical integration, and also ethical and community challenges. So for the data, right, we're really talking about pulling together and migrating multimodal data, which depends on quality, volume, and coverage, right? We need to take temporal data, multi-scale data, multimodal data, and pull this all together into a single model. That is an enormous challenge. The metadata is a challenge. The convergence is a challenge. And so really the gathering and storing of the data is so important to the digital twin. We need to capture data from the healthy patient as well as the diseased patient across populations and across the lifespan. The quality of the data is really important. A lot of times we have a lot of data on a particular population, but we're missing data for some of the sickest patients or some particular underrepresented populations. So big challenge there. And then also how we curate and harmonize these diverse data is an enormous challenge. Also, the data need to be stable and the provenance of the data is really important. But really what we want to do is pull together all these diverse types of data to get a more holistic view of how a digital twin might work. The second major challenge is how we connect these together. So this is a paper that we just had come out last week in Nature Machine Intelligence. And really, this paper talks about the challenges of this data fusion. I really think this is a huge challenge in how we're pulling together these different types of data and then pulling them together to make a single model or multiple models simulating this data and then bringing it back to the point of care. So, the patient is described in many different data points, and these data are often captured in diverse systems by diverse people. Real opportunity for us to move from these siloed research endeavors to bringing together a community, as we're seeing here in this meeting today. There's huge opportunity to think about how we can advance our modeling and how data are represented in these different models. And then I really think that the model output and simulations need to be pulled back by the clinicians so we have more interpretation and explainability for the information. There's another challenge is modeling. So how we're harmonizing data, integrating models, and developing standards. We've heard a lot today about the mechanistic models, but also the data-driven models. So how do we pull those two types of models together? That's really the beauty of the digital twin, is where we're taking knowledge from our mechanistic models, agent-based models, pharmacokinetics, systems biology, et cetera. And we're integrating those with our data-driven models. So I'll give you an example of the way we're thinking about this in a couple minutes, but how we cluster real-world patients and then fill in those gaps with our mechanistic models is a big challenge. But from an academic institute, it's a huge opportunity for us to think about innovative ways to approach these model harmonization. And more importantly, this can only be done by establishing high performance computing opportunities, right? Because we're talking about massive amounts of data. When we develop the digital twin, we're really exploring simulation trajectories. So not only are we simulating the trajectories, but then we're clustering those simulated trajectories to identify what do these patients have in common. So we have to capture the model, predict in real time, and all of this is very computationally heavy and requires the infrastructure and supercomputers, certainly if we're talking about real-time feedback. And so how are we merging these mechanistic and data-driven models? There's a couple ways that we think about this, and we've heard about some of these today. In our group, we're using ensemble models and some Bayesian inference models, but there are ways to do data assimilation where you can develop the model using your data-driven approach and calibrate using the mechanistic model. You can use a hybrid model where we combine both models, allowing for flexibility and adaptive models. We use an ensemble model in my group, which is combining multiple models, each with different assumptions and approaches to generate a more robust prediction. And then, of course, Bayesian inferences are coming into play here a lot, where we're seeing a probabilistic framework that combines these types of models, allowing for uncertainty in both the structure and the data. But I think there's also endless opportunities, right? These challenges are real challenges, and we really need a lot of community support to come over these challenges. But what are some of the opportunities? I think there's a huge opportunity to think about the digital twin in rare diseases, as we've heard from some of the talks today. There are individual implications, right? We can provide insights to the best predicted treatment combinations and improve decision-making beyond the individual. And improve decision-making during treatment. We can make implications that go beyond the individual. So thinking about accumulated trajectories and outcome data to provide success on which treatment is appropriate for a given individual with a given genetic makeup, with a social history, et cetera. We can enable health systems to better prepare and respond to real-time health situations and health disparities. So the realization of potential, I think, is enormous, but it requires contributions from experimental, clinical, and really computational communities, which I think is a great opportunity to network and expand our work in these areas. And so in my lab, we're using digital twins across a spectrum of projects. We have right now, we're working on a digital twin for prostate cancer, where we have mechanistic models that we've developed, mathematical models to model tumor growth and circulating PSA in the blood in mice to look at the trajectories of tumor growth and circulating PSA. We also have about 20,000 prostate cancer patients in a data warehouse we've developed at Stanford. So we're looking at when we have a patient come in, they have a disease, they might have radiation, they come back 8 years later with a new tumor, and we're fitting those mechanistic models on top of these gaps in our real world patients to understand how we can better understand the trajectory for this individual patient and see what would be the optimal treatment pattern. We're developing a digital twin for breast cancer, for triple negative breast cancer patients, where we're clustering patients by their characteristics, identifying patterns in their response, and then simulating different treatment responses based on patient signatures. And then we've also been looking at digital twins for postoperative pain management. So building trajectories after surgery to optimize our pain management work. And I'm just going to show you one or two pieces of work that we've done on this postoperative pain management, because we have a lot of inquiries about pain management in our pediatric population and pain management in patients with mental health disease, all of these different combinations of patient characteristics that need to be taken into account when we think about pain management. So let me just show you what we've done for this. So this is some work we've done where we have about 10,000 patients. We're looking at postoperative pain management, postoperative pain trajectories. So we have at least 3 pain measurements 3 days after surgery. And we've clustered these trajectories using a principal components analysis, and we identified 4 unique clusters. Within those clusters, we then looked at the pain trajectories, the average pain, the estimated trajectory for each of those clusters. And we see 4 distinct patient trajectories. And so then what we can do next, or what we're trying to do now, is we're trying to say, okay, you know what, here's my patient right here in cluster 2. They have the same characteristics as these patients here in cluster 2. So then can I simulate or predict their pain outcome following surgery? So I might identify the optimal treatment pathway or the optimal pain management for this particular patient who I know is going, or who I estimate is going to have this type of postoperative pain trajectory following surgery. So just an example of some of the work we've done. I know this was very high level, but I really wanted to, help us start thinking about, what are all the different applications of the digital twin in rare diseases and in this domain. So in summary, I think what we really want to do is we want to start moving from these general predictions to start looking at individual patient characteristics. And from those individual patient characteristics, we can start making individual predictions and identify optimal treatments based on these diverse information we can acquire on the patient. And then in summary, this can really help us build these cohorts of patients. So we can have this cohort of digital twin patients where we can use these to really optimize clinical trials. We can do many population studies, and we can guide our basic science research for hypothesis testing, looking at all different types of avenues. And so with that, I am going to stop there. This is, of course, a very large endeavor that we have so many people working on this. This is my contact information, and I will be happy to take questions. My Twitter account has recently been stolen or hacked, so please don't try and contact me via Twitter. But happy to take any questions that you might have. Thank you.
Thank you. That was fantastic. Would you like to answer 1 or 2 questions from the chat, and then we'll move to the next speaker?
Sure.
I think there were a few there. Can you see them?
Okay. Yeah, I can. Let me just see. Okay. So how digital twin is different from virtual patient concept used in the QSP models. I think there's a lot of overlap, and I think there's a lot of definitions that we're using out there. I think the main difference from the virtual patient concept is a digital twin is really about simulating outcomes across treatment options. So I really want to take my patient and I want to simulate how they might respond to drug A, B, or C, or treatment X, Y, and Z. And so it's really about that simulation of treatment options. And another question is, should the digital twin be integrated with xenopatient trials, especially in oncology, to maximize success? Absolutely. I think there's a great opportunity to think about this and how we can integrate these, across these different these different research endeavors. I think there's a lot of opportunity to really think about how we can maximize success. And if the digital twin can help us identify areas where there might be adverse event, or there might be ways we can optimize some of these designs, I think it's really important to think about how we might think about that. There's another question. A digital twin could be considered to be a virtual patient tied to a specific individual through some sort of ongoing data feed. Exactly. The basis of the digital twin specification can be derived from the mathematical structure of the digital patient. Yes, I agree. And so are there any successful cancer digital twins? Do you already have a success story? So we do have a success story in, well, it is still, I think it's still work in progress. We have a couple of great pieces that we're coming out with in prostate cancer. We haven't published these yet because it's still work in progress, but we are able to fit our mathematical models onto, for our PSA, onto our circulating PSA in our individuals, and really fill in a lot of these missing pieces when we're looking at trajectories for PSA trajectories in our prostate cancer patients. There's also been a lot of work in breast cancer where I think there's some great work coming out. I do think we're still very early in this process, and I think that the more people we have interested and the more people we have thinking about this and working about this, the better we can form these collaborations, and the better we can think about this as a community to really optimize the potential. So I think that, let's see, so there's a question on the current reality is that the regulatory position is interesting, but show us the evidence first, right? I think so. I think it's very difficult because this is really a vision for where we need to go, right? The digital twin is, I haven't seen a digital twin actually in place at any point of care. So this is a vision where we want to go. And so it's very, there's a lot of opportunities, but I think we're still getting there. So proof of concept is still needed. One of the things we're thinking about is, how could you think about the digital twin in phase 1, 2, 3, and 4 of a clinical trial, and what would that look like? And I think that's really great to see what's going on. And so I think I will stop there. Okay. A lot of more questions.
Thank you. We will go on to our next speaker, and then we will have you in the Q&A session after the next two speakers. Okay. I would next like to introduce Dr. Gadkar, who is the Senior Director at Denali Therapeutics.
Thank you so much. Just wanting to make sure you can hear me.
Can hear you fine.
Perfect. I'll start sharing my screen. Great.
Perfect.
Okay, perfect. Firstly, thank you for the organizers for the invitation. Really happy to be here. Great talk so far. Happy to contribute this work that we did at Denali Therapeutics. I'm going to talk about some modeling work which we have done for a CNS enzyme delivery molecule that we have for Hunter syndrome. I have a very brief one slide, background on this disease indication. Hunter syndrome is essentially a inherited lysosomal storage disorder, and it's primarily caused by deficiency in this enzyme, which is called IDS. And given the deficiency in IDS, the hallmarks are accumulation of glycosyluminescent glycans, typically referred to as GAGs, and the more prominent ones are heparin and dametin sulfate. And this, deficiency in IDS results in, impact in multiple tissues and organs, and there is a neurodevelopment deficiency in at least 2/3 of the patients that are impacted. Now, the current standard of care is essentially, having enzyme replacement therapy, and the approved molecule that we have is Elaprase. And one of the limitations, if you may, for this IV infusion of Elaprase is the molecule is not able to cross the blood-brain barrier. So it is not able to impact or bring benefit to the patients with the neurodevelopment deficiencies. So the brain delivery of the IDS enzyme still remains unmet medical need for Hunter syndrome. Now, there are many molecules that are in development. Some of them have been approved in certain parts of the world, but this is research and clinical development that is ongoing. There are 4 molecules here that I would talk about, and I'll describe them in a little bit more detail in the upcoming slides. The molecule that Denali is working on is referred to as ETV-IDS, and I'll talk a little bit about the enzyme transport vehicle referred to as ETV. In this format for the molecule, what is developed is a transport vehicle, which is an FC region with a region that is coded that binds our transferrin receptors at the blood-brain barrier. And the enzyme is then subsequently linked to this FC entity. Now, this transferrin receptor binding module helps bind the molecule at the blood-brain barrier to the transferrin receptors, and then subsequently transcytose the molecule across the BBB to the CNS, and hence enabling delivery of the enzyme to the desired target. What we expect is, IV infusion or IV delivery of the ETV molecule will address the enzyme deficiency in all peripheral tissues, but more importantly, address the deficiency in the CNS. And that is the MOA of the particular molecule. Now, as I had mentioned, there are other molecules that are in development, and I'll briefly go through these in this slide. The first one is the ETV-IDS that I just described, and indicated there in that orange color is the TFR binding epitope, which helps cross the blood-brain barrier and deliver IDS enzyme to the CNS. Another molecule, IgG-IDS, is along the same lines of TFR binding entities. Now, these entities in this molecule are in the Fab region of this IgG1 molecule, and we have enzymes linked to the FC region. There are differences in valency and also binding affinities to TFR between the 2 molecules that we have talked about so far. Elaprase, as I mentioned, is the current standard of care. This is the naked IDS enzyme delivered intravenously. And there has also been work done with elaprase dosed intrathecally. Now, one of the challenges we had while developing this molecule was to establish, biodistribution of the enzyme for ETV IDS, but also more importantly, to understand, the differentiation of the molecule that we are working on with, other molecules that are being developed, and establish, relationship between differences in biodistribution and then subsequently, biomarker responses, and then eventually, clinical benefit. So for this purpose, we developed a modeling framework to compare these molecules. And based on the talks being discussed so far, right, we have a good appreciation of the data that is available in this particular, therapeutic indication will be very limited. So getting a good mechanistic understanding and using all the available data across preclinical and clinical species was very relevant in this particular effort. Now, starting with the focus of getting a better understanding of biodistribution, we wanted to understand, what the mechanisms are for the biodistribution of these different molecules. And here is a very simple schematic of, 3 compartments, if you may. The circulating compartment or the plasma compartment, where we have IV administration of the molecules that we have included in this analysis. We have the brain or the CNS compartment. What separates the plasma compartment and the brain compartment is a blood-brain barrier. And for typical molecules, we know that it's very difficult to cross this blood-brain barrier. We also have the CSF compartment, and that is separated from the plasma by the blood CSF barrier. And essentially, your CSF is the fluid around the brain, and distribution or transport between the CSF and brain is primarily through, diffusion exchange, which is potentially non-specific. Now, if we look at the molecules that we have included in this analysis, we have elaprase, which is the naked enzyme, IDS, and it does not have any, facilitated uptake into the brain to cross the blood-brain barrier. So that particular molecule dosed intravenously will typically get into the CNS via the CSF, shown by that arrow, or non-TFR mediated mechanisms. And we have TFR mediated mechanisms, which are, utilized by the ETV IDS molecule to cross the blood-brain barrier, to have transport across that blood-brain barrier and have more uniform distribution across the entire volume of the brain. And now, in addition, we have IT elaprase, which is dosed and shown in this diagram is an arrow getting into the CSF. One thing that we were, challenged with is understanding the transport between CSF and brain, and more importantly, understanding how that information that we have from preclinical species translates to, clinical settings. Now we did, first order diffusion modeling work and getting a sense of distribution from the CSF into the brain regions. And what we, identified based on that is, if we have, concentration in the CSF, and on this particular, schematic, the CSF is represented as, say, 100%. You see that the diffusion into smaller species based on, the volume and the size, you get good distribution into the mouse brain, for example. Less efficient in the monkey brains, but the efficiency is far more reduced in human brains, just based on the size of and diffusional parameters in these settings. And this essentially motivated us to have a representation of what is typically, used in the blood-brain barrier field as, the superficial brain region and the deep brain region. And that is shown by that schematic on the bottom right, where exchange between the CSF and the brain was restricted to what is referred to as the superficial brain region, but transport from CSF does not get into the deep brain region. Now, what is also shown in that schematic is molecules that are using receptor-mediated uptake, in this case TFR, cross the blood-brain barrier, and through the transcytosis process are able to distribute uniformly to both brain superficial and brain deep regions. In this case, it's uniform distribution over that entire wall. So with this in mind, we started this modeling effort where we have, representation in systemic circulation, and we have typical mechanisms of clearance and distribution for these molecules in the peripheral tissues. What we have represented is IV administration of the three molecules that I've talked about. Explicit representation of TFR-mediated uptake into the CNS through the vascular transcytosis process, and also non-specific uptake into the CSF, and then exchange between the CSF and the brain superficial region. Now, getting the IDS enzyme at the site of action, which is the brain, then results in your desired, PD effect of normalization of these accumulated GAGs. And in this case, the primary biomarker that was used was heparin sulfate. And these biomarkers then subsequently get measured in the CSF in clinical studies. Now, what is also interesting in this particular schematic is, if you notice, the exchange between the CSF and the brain superficial region for the pharmacokinetics of the drug, or the PK of the drug, reflects in the distribution of the biomarkers, where the CSF is a reflection of what is happening in the superficial region of the brain, and not necessarily the entire brain volume, based on the same arguments that we've just described on the previous slide. And for the two molecules that use TFR-mediated uptake processes, then understanding the mechanisms of binding to TFR receptors, the impact of the affinity, the impact of the valency differences between those two molecules became very relevant in understanding the differential uptake efficiencies for ETV-IDS with IgG-IDS molecules. And now, just based on this, schematic, we can imagine that, the number of parameters, if you may, in the model, or the unknowns are fairly, the list increases, and then we rely on some preclinical data to get some estimates and understanding of the relative magnitudes of those mechanistic processes. Now, most specifically here, we wanted to understand the distribution of these two molecules that use TFR-mediated uptake in the endothelial space, and what gets into the entire CNS volume. And here we used our preclinical data that was generated in mice. Now, on the left panel, we are looking at plasma PK and brain PK for the ETV-IDS and the IgG-IDS molecule. And the model was able to capture these data across a range of doses fairly accurately. And what we also had information on is the ratio of the distribution between the parenchymal volume and the vascular volume. And over here, we see significant differences in the data which the model has been able to capture in the biodistribution of ETV IDS more into the parenchymal space, whereas the IgG IDS, given the TFR affinity and given the bivalent nature of the binding, was essentially trapped, if you may, in the endothelial layer. And this essentially was critical in understanding the biodistribution differences between these two molecules. So now with data that was available in the preclinical setting, we switched to translating this model to a clinical setting. And I'm not going to show all the calibration data, but let's get into the predictions that the model is making in the four scenarios that we are referring to or looking at in this case for ETV IDS, IgG IDS, and elaprase through two dosing routes of delivery. These are clinical simulations, and what I'm showing in the first panel is the clinical measurements that are available to us, and these are representative reference simulations, if you may, that capture the limited clinical data that is available. What we have on the top panel is plasma PK in humans, and what we have in the bottom panel is the heparin sulfate reduction that is measured in CSF. The key points I would make here is, given the PK characteristics of these molecules and TFR-mediated clearances in systemic circulation, there are differences in the exposure between ETV IDS and, say, IgG IDS or even elaprase. We have intrathecal administration of elaprase, and what gets into systemic circulation that is measured is fairly low. And what is measured is the CSF HS reduction. And this potentially is not the entire story, because what we want to get a better handle of is what is the heparin sulfate reduction in the brain, and more importantly, not the superficial region of the brain, but that entire brain volume. But what we measure is what we have access to in the CSF. And I just want the audience to kind of just take a pause and kind of make a mental prediction of what you would expect for the CNS prediction. And I'll walk through that in the next build here. Now, what we have here is the predictions now for the superficial region of the brain. And those predictions, if you focus on, say, IT administration of elaprase, you see very high exposures, and that is expected because you're dosing directly into the CSF region, and there is good distribution in the superficial region of the brain. But now, if you look at the predictions for the same IT administration of elaprase in the deep regions, you see that purple profile is fairly low. That means the penetration into the deep region of the brain is not captured or predicted by the model based on the data that we have. What we are seeing is the predictions for the PK for ETV IDS and IgG IDS are fairly comparable in both brain regions, superficial and deep, and that is consistent with the mechanism of uptake that we are established across the BBB using transcytosis. But you see that there is a differential in exposure between ETV IDS and IgG IDS just based on the distribution of parenchymal to vascular ratios that we saw from the preclinical studies. And as expected, the IV administration of elaprase is known not to get reasonable exposures or any sufficient exposures in the CNS, and those green profiles are fairly low. And the PD responses now reflect the drug concentrations at the site of action, where you see good biomarker reduction in the superficial regions of the brain for IT elaprase, but that does not necessarily, happen in the deep regions of the brain, which are shown by those purple profiles being hardly moving, and the effective reduction across the total volume of the brain are fairly modest for intrathecal administration of IT elaprase. But what is also observed for ETV-IDS is consistent reductions in both superficial and deep brain regions, normalizing heparin sulfate to normal levels, and that is achieved across both superficial and deep brain regions, reflected by the average total brain heparin sulfate predictions. And for IgG-IDS, the reduction is uniform, but is not as impressive, or the magnitude is not as effective, just based on the fact that the exposures were not sufficient in the CNS regions. And this, gave us confidence to conclude the rank order, if you may, of the heparin sulfate reductions that were expected at the proposed, clinical doses during drug development of the ETV-IDS program. So next, we wanted to make sure we explore some variability in the underlying biology or uncertainties that we have in the model, to see if these conclusions hold true to some of those explorations. And I'll use one example. What I did describe is there was some uncertainty, or unknown, if you may, based on the distribution from the CSF to the superficial region. So what fraction of what volume of the brain is superficial versus deep? There was some uncertainty in that. And we explored that more specifically to compare the results of ETV-IDS with IT administration of elaprase. And based on exploration of the range of uncertainties and variability that we could anchor on, we saw that the penetration of intrathecal administration of elaprase, even in the best case scenario, was not sufficient to have normalization of heparin sulfate across the entire volume of that brain. So the purple band shows the extent of the predictions from a virtual population, if you may. So this again, adds more confidence to the program with the data that we have at hand, and then focusing on planning phase 2 and phase 3 studies. We wanted to use this model to then subsequently pick the dose, if you may, that we have most confidence in to bring therapeutic benefit to patients. And what we have in the first figure there is dose on the x-axis. We are looking at heparin sulfate reductions in the primary y-axis, and the predictions of the brain drug concentrations on the secondary y-axis. And the dotted line is the level of normalization for the particular biomarker, which is represented as percentage change from baseline. And we want to get normalization by reduction of 85% plus. And we observe that a dose of 1.5 gets you there. Greater doses will definitely have additional improvement, but we do get the desired activity at doses 1.5 and greater. But we also wanted to be very mindful of the variability that we would expect in the clinical studies. And in order to do that, we explored what was referred to as digital twins or virtual populations in previous talks. And I'll show one representative simulation here, where we are looking at responses of two patients that are essentially identical, except for the one difference that we wanted to have explored in this analysis was the impact of ADA on PK. And here I'm showing simulations for 15 mg per kg weekly dosing for this particular set of digital patients, where one does not have an ADA impact on PK, and that is shown by the gray profile, and we are getting good normalization, 90% plus reduction in heparin sulfate. But for this particular subject, with even a impact on PK with because of anti-drug antibodies, 15 mg per kg dose was effective in having reductions in the heparin sulfate. Again, excess of 85% plus, and based on this kind of analysis, a clinical dose of 15 mg per kg was used to move forward in the clinical studies, and this was essentially to make sure that this is a rare disease, and we did not want to have any patient that can potentially get a suboptimal dose, even in the presence of variability in PK or the impact of ADAs on PK. We wanted to make sure that our clinical dose works across the entire 100% of the patient population. And this is currently ongoing clinical studies. What would be interesting to then subsequently get data for is cognitive function, and link these biomarkers to those, and then eventually expand the scope of this quantitative work to get a good understanding of not only the mechanisms of biodistribution but also underlying pathophysiology of the particular indication. So I wanted to conclude by again a schematic of the biodistribution, and I've used color scales here where we have the drug concentration of the enzyme color coded between a bright shade of blue, which is high concentrations, to gray, which is low, and we see that the site of action, which is the brain, is having the brightest shade with the ETV IDS molecule. And just understanding the mechanisms of biodistribution, uptake into the brain, getting a good understanding of preclinical data to understand what gets trapped in the endothelial versus having uniform distribution across the entire brain volume, exploring routes of administration via intrathecal route was all encompassed in this particular platform model, which gives us confidence in this molecule and the performance of that to support the clinical studies. With that, I wanted to conclude. I would start by acknowledging the patients, the families, and the data that we are generating with our clinical collaborators, which has been immensely useful to support the program and the modeling effort that is used in it. Special call out to Mohammed Jafar Nejad, who has been in my group and has been the point person working on developing the model, and the entire team at Denali, and more specifically the ETV IDS project team. Thank you.
Thank you. That was fantastic. We are a little short on time right now, but we will get you some questions when we get to the panel discussion.
Great. Thank you so much.
Thank you. Okay, our next speaker is Dr. An. Dr. An, are you ready?
Thank you.
My name's Gary An. I'm a trauma surgeon who's been doing computational biology for
about 25 years. I do not deal in rare diseases, and I don't do quantitative systems pharmacology. So, and this has been a fascinating, webinar to listen to. And many of the things I talk about today will have already been discussed at some level, right? So this is a mouthful of a title. And as evidence of kind of parallel evolution, we came up with this idea of translational systems biology, which is a computational representation of biological processes, and the use of in silico trials representing clinical populations as a means of accelerating the drug development process. So, probably kind of around the same sort of time that QSP was coming online, but as you'll see in a second, a little bit of a different focus, which I'll try and highlight here. So, as a clinician, we're very aware that people who seem ostensibly the same can behave very differently. And when precision and personalized medicine came around, I thought there was a lot of promise in the meaning of those particular words. And it turns out that, the manifestation isn't necessarily exactly what I had hoped it was. So I came up with some of these axioms of true precision medicine several years ago. And if you look at this, this should be intuitive, right? That patient A is not the same as patient B. Patient A can change over time. The goal of medicine is to treat and not just prognose. And this last one is really important and potentially intersects my own interests with, the rare disease community, which is that precision medicine should try and find a solution for everybody, and not just optimize existing therapies that have been demonstrated to work in subpopulations. So with that in mind, at some level, personalized precision medicine is kind of like a rare disease. Because of the curse of dimensionality, when we're looking at the number of potential features and potential interventions for a particular disease process versus the number of patients that actually manifest that particular disease and that particular configuration and the variance across the population, the heterogeneity that's been mentioned in this meeting, that leads to a perpetual sparsity of data because you need a 2 to the n number of features to be able to partition between one group versus another, right? So is addressing the challenge of a rare disease is similar to trying to achieve the goals of personalized precision medicine. So, as a surgeon who deals with sepsis, I'm very aware of the inability to come up with effective therapeutics despite a huge amount of knowledge regarding the underlying pathophysiologic mechanisms. And there's this valley of death that's well described, that's out there. And a lot of times, a great deal of breakthroughs in drug discovery are focused on the left side of this particular chart. And when you get to the valley of death, which is the translation into a clinical population, this is where things kind of come to a crashing halt. So QSP, to my understanding, operates kind of over on this side. And what I'm interested in is kind of the step before you get to the potential candidate in which you're doing trying to determine whether or not a particular drug will do what it intends to do, and ask the more upstream question of whether it is actually even a good idea to intervene in a particular pathway, knowing that despite, an emphasis on a particular pathway, there's n number of pathways immediately adjacent to it that are doing parallel or counter things that are not static, that are going to respond to a perturbation of the pathway that you're interested in. So the interpretation of the mechanistic context of our biological knowledge into a new clinical context in which it has not previously been tested, so this will be drug repurposing, or the construction of a new potential intervention point, which are the new drugs or combinations of drugs with multiple control points, all those sorts of things fall into this kind of cloud of trying to determine what could conceivably work, assuming a perfect interruption of that particular pathway. And this is where what I'm interested in is distinct from all the regulatory and the engineering aspects of QSP, et cetera, which are incredibly important. But to my, my particular interest is enhancing the efficiency of the candidates that get to that particular point. Because I would hate for people to spend all their time working on these sorts of things and then end up with a target that, when introduced into the full complexity of the biological system, doesn't do what you want it to do. Right. So one of the reasons that this valley of death exists is because we don't have first principle, ab initio modeling like you can for physical systems. So if you had natural laws and constraints on what can be expressed by natural laws, you can come up with predictive models that I would consider to be engineering grade. And the fact of the matter is we don't have that. We're dealing with perpetual epistemic uncertainty and incompleteness of knowledge, and we need to try and somehow figure out how we can come up with useful interventions and controls, recognizing that we can't know everything about everything. And then this other problem associated with the fact that we don't have the behavior of our system grounded in first principle laws is we don't have solid footing on representing where the biological heterogeneity that we see comes from. Plus the fact that most of our investigatory processes are insufficient in being able to characterize what this is. So this is the denominator problem, which represents all the possible configurations that a biological system has, is vastly greater than any sort of sampling you can have of that particular system in order to have any confidence that you've completely sampled the possibility space of that particular system. And I'll get to that in a second. Right. So what do other sciences do? They do engineering, and they do engineering because they have formal processes that can apply to systems in a space of constraints, right? And they use math and formal representations that are trustworthy because many of these particular systems that are engineered upon are governed by natural laws. So you can have a certain degree of confidence that if you are trying to create a mechanical object or engineer a chemical process, that the laws of chemistry and physics will allow you to have some confidence in the formal representations that are operated on by that engineering task. So the problem with biology, as I mentioned, is that we don't have natural laws. There are no ubiquitous, trustworthy formal representations. And reverse engineering is extremely difficult because biological systems have non-path uniqueness. You have multiple different microstates that can lead to the same system level phenotype. And there are epistemic limits associated with current investigatory processes, though they do the best that they actually can. Right. So how then, knowing the difference between biological systems and physical chemical systems, can we use mathematical and computational methods to overcome these limitations? So Dr. Hernandez-Boussard gave a great talk about megadigital twins, and we've heard about virtual population and in silico trials. And the question is, how can you operate using those particular concepts for this particular constrained task of identifying what you should try to develop into a pharmacologic agent? And how do you do that? Right. So what are the steps that are necessary? What sorts of fundamental theorems or laws or principles govern how you approach this? Right. Because you should be able to, as has been discussed, make all sorts of in silico trials with virtual patients or digital twins and come up with a punitive idea of what might work. But right, the question has to do with what you put into those models, how do you represent them, and how do you actually capture the true heterogeneity across the population, recognizing that you usually are undersampling what is possible there. And since you can't have full knowledge, ontological truth of this particular system. How do we deal with the fact that we don't have complete representation of the system that we are trying to apply engineering principles to? So there is this principle, the maximal entropy principle, that is drawn from information theory, statistical physics, right? Which is based on the idea that you want to minimize the bias when you're talking about the possible configurations that are available to explain a particular phenotype, right, or data structure or whatever. And so let's say that you have a particular list of components, right? You have the time series and you have multiple divergent phenotypes or system states that you end up with. What is the least bias set of interactions between the available components that can produce that particular thing, right? The idea here is it is the opposite of parsimony, right? Because parsimony assumes that you can make the assumption, and that assumption, that abstracting assumption, is powerful enough to represent the behaviors, the richness of behaviors that are of interest, right? So when you're dealing with populations and means and things like that, that's probably okay, right? But this goes towards personalization and the idea of individualized digital twins and heterogeneity across populations. You actually want to be able to represent the richness of all the possible trajectories that are possible given the set of known components, right? So this idea of maximal entropy is intended to enrich on top of any preconceived specified model structure that you actually have, right? And this is important when you're trying to come up with a robust intervention, because you want that intervention to be applicable across this range of biological heterogeneity, right? So on one hand, you're dealing with a very, very large dimensional space, right? That is even less constrained than you think it is based on what you represent in even a complex model, which I will show an example of in just a second. You want to embrace the heterogeneity of the data sets that you have, because the one thing that you know about the biological system versus a particular data set is, barring measurement error, that biological system was able to produce that piece of data, right? This means that the outliers are incredibly important. And it also means that the outlier that you have isn't necessarily the outlier that is there if you had another sample, right? So you need to somehow encompass that heterogeneity in your particular representation. The thing that makes this potentially tractable is that you're looking for a control strategy or a control point, right, that is effective across as wide a possible representation of that heterogeneity that you can have, right? And this is where the context of a control discovery task, right, which is the precedent to finding a particular pharmaceutical agent that you can do the QSP on, right, is important. So a rational approach to identifying control requires, or should require, hypotheses about how that system works, right? So this particular community recognizes the importance of representing mechanism. As a, a bone to throw to parsimony, you want to use the minimal model necessary to establish control of the desired things of features of the system, which means that at least you have to be able to represent the data that is being used to calibrate and validate the model. And you need to have sufficient mechanistic representation of the target that you're going to try and exercise control on to minimize the number of assumptions that you have as a consequence of manipulating that particular variable, right? You want, again, something that is robust across biological and clinical heterogeneity. And then this is an iterative refinement process that takes advantage of not only more data, but ideally more heterogeneous data. So the example previously presented of the disease that was manifesting in pediatric and adult populations and demonstrating that the same shared pathophysiologic mechanistic representation could produce both of those particular disease states is where this power comes from, because what you're looking for is a computational representation of what is conserved and shared across a population. So this is a particular mathematical object that addresses that, right? So this is a non-standard means of thinking about parameters, where instead of thinking about them merely as the coefficients that affect the strength of a particular set of rules, right, the coefficients also denote the existence or the absence of an interaction that may not be explicitly represented in your particular model's wireframe diagram. The justification for this is we have a reasonable guess that a lot of the non-represented or unknown genes, pathways, epigenetic changes, whatever, in your particular system represent means of tuning the gain of the rules that you have represented. So we have this particular object, the model rule matrix, which is a matrix that takes all the molecular or genetic entities that you have in your representation versus all the rules that would represent all the interactions present between those particular entities within a particular rule, right? And then you operate over this n class n times m matrix to come up with a set of model configurations. They're model configurations that cannot be falsified given a particular data set. And I'll show that in a second here. Right. This is the paper that goes along with this description. So here's a example of this. So we have a relatively complex agent-based model of sepsis, the innate immune response agent-based model. It's almost 20 years old now, but it has been validated and remains to be, not falsifiable. It is reasonably complex. It's got like 25 different rules managing 17 different mediators and all the different cell types that you see there, et cetera. And it is used to simulate systemic inflammation and sepsis. Right, so we take this particular object and construct a model rule matrix, right, which is a 17 by 25 matrix, right, of which each particular matrix element represents a connection represented in a rule, a cellular molecular rule in the IRABM. What we do then is we take a data set. In this particular circumstance, it is a cohort of 199 trauma patients, 92 of which developed acute respiratory distress syndrome and 107 that did not. For which we have actually pretty good time series molecular data in the things that you see there, as well as a organ level score, which represents a physiological aggregate. We've developed a fairly complex machine learning pipeline that involves genetic algorithms and active learning operating on high performance computing to operate over this particular rule matrix with the sufficiency criteria that at least one of a number of stochastic replicates of a particular configuration of the model must be able to generate the data point, the outlier data points present in the data set. So here's an example, just a heat map representation of what the MRM looks like. So on the left is a relatively sparse matrix where the colors represent integer values that are in the initial rule set. And you see that it's pretty sparse. All the white is no explicitly represented connection. And then when you operate over this and allow this matrix to evolve over time using a GA, you come up with a calibrated MRM that demonstrates a much higher degree of connectivity. And it's actually probably more biologically possible because we know everything is kind of connected to everything else. We don't only use a single evolved MRM. We have an ensemble of these that meet the sufficiency criteria. And this is a heat map of what those values are with a 3D representation of what the ensemble of models that would be used to execute simulations to create the synthetic data. And this is what the synthetic data looks like across three different types of cytokines. We have 17, but it's matching all of them. All right, so what we see here is the raw data points are the red dots, the red dots represent those patients who will develop ARDS. The blue dots are those patients who do not develop ARDS. You can see that that data looks very much like molecular time series data. It's all over the place. There's no clear distribution, and there's a lot of overlap. If you tried, and we did, run statistical tests on this, there's no separation between those populations, though we know there's a clear phenotype that's different. The dashed lines in panel A on the left represent real time series collections. And then the colored spaces represent trajectory spaces generated by that ensemble of models given the sufficiency criteria of being able to meet the data of that particular type. And therefore you can see, right, that there's this greater richness of representation present as a result of that particular, let's call it calibration process. Now, it's not, it's really, really large, right? I mean, it's like really large, but it's not infinite, which is a common critique with highly complex, multiply parameterized models, right? And on the right side, you see the same sort of principle with respect to two other mediators. And on the left is a proof of, a system level validation showing the organ failure score, which is a marker of ARDS, which is not explicitly represented in the model, but is able to be generated using the partitioned configurations of the MRMs for the ARDS and non-ARDS populations. All right, so I'm going to run through this really quick because this is not actually something that's related to much of what's talked about today, but since it's here, I'll just go real quick. And this is the idea of using deep reinforcement learning and artificial intelligence to identify multimodal and personalized control. So the idea here is that those multiplicity of trajectories essentially means that you can't pick a static control drug treatment regimen for patients because they're different at different times and they have different response levels, et cetera, et cetera. And therefore we use the same AI training process that's used to train the game playing AIs, where they play a game against the AI ABM in order to cure it. So our particular, this particular example has to do with an attempt to try and control sepsis due to a bacterial pathogen for which there is no effective antibiotics, something that's coming along pretty, unfortunately, pretty soon, right? And the idea here was, can you repurpose existing anti-cytokine drugs to control a runaway infection in a population with a pretty high degree of mortality? Right, so we had a 40% mortality in our base case and dropped that to 10% mortality. It did, however, require manipulating 6 different mediators at different levels at various times. And this was a robust policy derived by the AI because it worked across regions of parameter space in different MRMs. So here's an example of what those control actions are. On the left, you just see what the manipulation happened to be. And on the right, you can see that 3 different patients, 3 different simulated patients with different trajectories with the same policy required interventions at different times, at different levels, and all of these were able to survive. So this is the personalization component. This is the path towards medical digital twin that can be used to guide a control system intended to control sepsis. All right, so in conclusions, right, this particular approach I'm talking about is upstream of QSP. We're not really talking about all the intricacies associated with the effective delivery of a particular compound to its area of intent, but rather, is it actually a good idea to target this particular pathway? I would say that the rare diseases and true precision medicine have very similar approaches, where you are trying to essentially deal with which are individually sparse and distinct examples of trajectories. We need to be able to figure out a way how to encompass biological heterogeneity in the face of epistemic incompleteness. We use this principle of maximal entropy to make sure that we haven't missed something and provide a test bed for the robustness of any control that we come up with. And it requires a fairly substantial change in mindset, because now you're dealing with extraordinarily large parameter sets. You're dealing with non-parsimonious models. You're dealing with millions and billions of simulations. It is, it's daunting. But the principle, the theory here is that you can't actually do it any other way unless you are hoping that your level of abstraction is sufficient to capture all the things that you possibly could have missed. Right. So this little diagram here has been verbalized by other people in the webinar, previously, with the idea that if you develop a pipeline that takes advantage of computational methods, you can accelerate the throughput across the valley of death and come up with a better list of candidates that you can then do QSP on, so that you can actually be more efficient in finding effective therapeutics. And that is it. Thank you for your time.
Wonderful. Thank you. That was certainly very relevant. So now we're going to move right into our panel discussion. And so the last two speakers, you can ask questions of them in the panel. And I'd like to invite Dr. CJ Musante, Vice President of Scientific Research and Global Head of QSP at Pfizer, to moderate this session. And all the people who are in this panel, please turn on your cameras so that we can have a great discussion.
Great. Thank you very much, Dr. Stinchcomb. And I'd like to first introduce our two new panelists in addition to the speakers and the session chair. So we also have joining us on the panel, Dr. Jack Wang. Jack is the team leader for the Rare Diseases and Inborn Errors of Metabolism Review Team in the Division of Translational and Precision Medicine in FDA's Office of Clinical Pharmacology. And also Dr. Hao Zhu, he is the director of the Division of Pharmacometrics, also in the Office of Clinical Pharmacology at FDA. So welcome to you both to the panel. So I had a prepared first question about how virtual populations and digital twins could be used, especially in the face of small data sets, sparse data sets in rare diseases. However, there's been an interesting discussion in the chat that I'd like to focus, maybe start out with. And that's around this idea of digital twins. Is there one digital twin per patient? Or, as in previous examples that we've seen, that are there multiple versions of that patient that we should be exploring because of the inadequacy of the data that we have currently? And I think one may be the ideal and the other may be the reality, but I'd like to have the comments, especially perhaps we start with you, Dr. Hernandez-Boussard.
Yeah, so I think that's a great comment. And I mean, ideally, you want one digital twin per patient that we can test multiple treatments across, because the issue is if you have several digital twins and then you test different treatments across those digital twins, you don't know if it's the treatment that's changing or your representation of the twin that's changing. So if we hold that single virtual copy of the twin in place, then we can test multiple treatments across that individual digital twin. So in the ideal world, I think it is a single representation of the patient. And the way we deal with missing data and missingness needs to be accounted for in all these different versions. But I think some of my panelists might have some other opinions. I don't think there's a correct answer to that. I think there's an ideal answer.
I agree. We're learning, right? We're still developing. Yeah. And I believe Dr. An, you had a comment.
Yeah, so I think, ideally that would be the case, but even in industry, engineered objects don't necessarily have one digital twin. They have different representations for different uses. So, the criteria for digital twin is a particular data structure that is defined upon what its intended use is going to be, right? And I think for a global disease process in which there are multiple interventions that can be applied, then you want to have a digital twin that can concatenate all those particular aspects. And I'm just saying this in the interest of inclusiveness, right? There is an extraordinarily wide range of what people consider to be digital twins. right? And we tend towards a let's call it an interventionalist sort of way, in which we want to actually kind of treat people. But there are multiple people who talk about digital twins for forecasting and prognosis, in which a intervention is not necessarily implicitly informed by that particular representation. I'm just saying, right? Not that I am interested in developing those sorts of things, but in terms of the wider community, there are people who talk about that. I think the intersection between potential interventions and the cross-pollination of different effects of a particular intervention on the underlying specification of a digital twin is something you need to be cautious about, as Dr. Hernandez-Boussard talks about. I think there's a pragmatic thing, which she alluded to, that we want to try and get stuff that's useful, perhaps early on at the expense of comprehensiveness for all potential eventualities.
Thank you very much. I think Dr. Gadkar has a comment as well.
Right. I'll add something to it. And, I must, start off by saying that the term digital twin may have, maybe used in different contexts in different ways. But one thought I had was, you have, limited data or clinical data for one subject, if you may, right? And there is a lot of uncertainty that you don't know. So you could have, multiple representations that still capture the data within the construct of your model by exploring, say, different hypotheses. And in that sense, right, I see, multiple digital twins representative of one clinical subject with maybe different hypotheses. And what I wanted to add was, you could have the same hypothesis reflected for another clinical patient where you have different data, or, that subject had a different intervention. And that may help you, narrow down your hypothesis space, because one data set may not be sufficient to explore all those hypotheses or eliminate those, but combination of those data sets may then eliminate some of those hypotheses across your virtual population. And what remains in terms of the collection of digital twins can then be your virtual population that you use for simulating, different therapies. And that same virtual population can be used to test multiple therapies at the same time, and so on.
Thank you. And Dr. Hernandez-Boussard, do you have a follow-up?
Yeah, no, so I totally agree with these comments. And one of the things we're kind of struggling with right now, so we have a triple negative breast cancer cohort. So in that cohort, we have, a couple hundred patients where we have a very deep dive into data. We have data on every single aspect, well, not every, on many, many different aspects of those patients. And on the other hand, we have another population of about 3,000 patients where we have sparse data on these patients. So nobody with a full deep dive on the data. And so we're trying to figure out, do we work on just that smaller cohort that might be less representative of the general population to really get a better understanding of sort of the mechanistics and the structures of the information? Or do we take that broader view where we can have more diversity and greater, I don't want to say noise, but greater differences in response? And I think that's a question that everybody's kind of grappling with in the community right now. And I don't think there's a good answer. I think when we think about the population and how a population might respond to a drug, a population of digital twins is different than my individual digital twin for a single person. So those are two distinctions that we should think about.
Thank you. And I see Dr. Wang has his hand up again. I also want to get our panelists from FDA to comment as well.
Yeah, so I would agree with these last comments from Dr. Hernandez-Boussard completely, right? This question of detailed representation and how do you expand to cover what is an understandable population. And this is where the generation of synthetic populations, and let's just use that term, synthetic populations that bridge what are otherwise rare or outlier or underrepresented data points in the population, right? So that is one of the intents of the breadth of the process that I described, because it makes no presupposition of what the statistical distribution is in the population of those particular trajectories. It just says a particular human being was able to produce X, right? And you cannot say, right, what particular configuration that particular person had or how represented they are in the overall population, but in the interest of inclusiveness and being able to represent the sum total of biology that's present, you need to be able to represent that. And then the thing that makes it a digital twin is a output of the model that can be represented in a real piece of updatable data that can tie the trajectory of that particular simulation back to the individual, right? So this is the clear distinction between a digital twin, right, and a synthetic patient or a virtual patient, right? It's the personalization component of it, or the capability to personalize that particular individual, that makes it a digital twin and ties it to a particular individual.
Thank you. And I would like to also perhaps ask Dr. Xu, kind of thinking about our breadth of modeling approaches that we use, pharmacometrics, systems pharmacology, the digital twins, compare and contrast this with population approaches in pharmacometrics. Do you have a comment to add?
Sure. Thank you. I think this is a great discussion. In generally speaking, from pharmacometrics approaches in general, we simulate individuals to drive certain decision making that can be extended to either and population level or get into more towards individual level. So digital twin is definitely getting more towards the individual level, where we can actually look at what I would use epidemiological term that is like a counterfactual events or counterfactual subjects, where we can look at what is going to happen in a parallel universe, if you want to call that. So then we can make a comparison from that angle. So if getting into that details, it really, the reason we have to generate it in reality with the different versions of digital twins, it probably lies in the fact, like everybody talks about it, it is the, sometimes in reality, here's the data, here's the information source we have that limits our capability to generate a full one model or one digital twin actually that can really represent everything altogether. Or there is a limitation about the modeling approach we are using here. So we wanted to look at the potential alternatives in that setting. So that actually gives another reason that we probably want to look at the different versions of digital twins. But I think everything we're trying to use, it really ties up to the final context of use. So it has to be fit for purpose. What is the objective for us to do this, and how large difference we're looking at, let's say, between the two treatment options where we're trying to make a comparison. I think, those are the things we probably want to put into the context about, which digital twin is more appropriate version we're going to use, and how we're going to use that to drive your decision or drive your conclusion.
Thank you very much. I want to move on to another question now, and this one I'm going to address to Dr. Gadkar and then Dr. Wang. So, we're talking a lot about rare diseases, but on top of that now we have new modalities that presented another challenge to us. Many of these diseases involve monogenic mutations. And with these promising modalities, for example, gene therapy and gene editing, can you talk about how QSP models can be used to assess, in conventional therapies, dose exposure response relationships for dose and dose regimen? And then also thinking about these treatments, especially for rare diseases that start in childhood, could QSP be used then to assess the durability of response? So perhaps Dr. Gadkar, you could start with that.
Yeah, and I don't know, this is a very, kind of generic answer, I think, and may not be, very satisfying, honestly, but I'll give it a shot. Yes, there are different modalities, and, what the QSP, platform or approach, enables is, getting those different mechanisms that are invoked by those different modalities in a consistent, unified analysis platform, if you may. So you may have, as you said, gene therapies, or you may have, the different routes of administration, as my talk had shown, or a whole range of different MOAs. what the QSP model will enable, as long as it's within the scope of what you're developing, is an integration of all the data across these different modalities into one unified platform for a fairer comparison, if you may, across those different modalities. And more importantly, it would be, learning from, data that is generated for other modalities in the context of, the ones you are working on, which on the face of it may not be, very easy to do unless you have this mathematical framework for evaluation. But I'm sure others can add to this.
Dr. Wang, do you have a follow-up?
Yes, that is a great question. So dose selection is critical for drug development, especially for rare disease. The majority of QSP submission to FDA, we have seen focus on dose selection to be studied in clinical trials with respect to drug effectiveness. And we do see also a small portion of QSP focus on drug safety, such as liver toxicity, risk of cytokine release syndrome. Our traditional dose selection has been relying on exposure response information for efficacy and safety using exposure data based on plasma concentrations. As we can see from a few examples today, QSP provide an opportunity to look at exposure response at the tissue, cellular, and even subcellular level. So those will provide insight into drug response and durability of the response for the drug. I think from those examples, we do see very high potential for QSP to guide dose selection.
Thank you very much. If there are no other comments on that, and I don't see any hands raised, then I will ask another question. So we've seen a lot of great examples today, QSP models applied to rare diseases, understanding the challenges in rare diseases as well. Are there any rare diseases or disease characteristics? So for example, we've seen inborn errors of metabolism, right? Are there certain diseases or translatable biomarkers, non-invasive biomarkers, preclinical models, patient registries that are more or less amenable to a QSP approach? And maybe I will ask that to maybe Dr. Zhu.
Yes, I think Dr. Musante, I think this is a great question. Like I said, my view is that the QSP is a very powerful platform. The powerfulness of QSP is actually has the capability to integrate all pieces of information together. So any disease that actually has, let's say, some relevant information which we can take into together would be probably the disease that QSP model can actually show more values. For instance, we have a good understanding of the biological process, which is common between certain disease and one specific rare disease, and then we can use that knowledge from the biological process and as part of the as part of the QSP model building. And also a certain drug response. If, for example, we're really looking at the repurposing of a drug, we have a fair understanding for this pharmacology already, and now we're fitting into a new disease progress. So that could be a good place that the QSP model can really help. So all in all, I think, any information that we can borrow from relevant knowledge and information sources, and we can integrate them together. That is where I see the QSP modeling can really help, and that's where those disease that has those features or has the relevant information actually can be really a good place that the QSP model can really play a role here.
Thank you, Dr. Xu. And I see Dr. Wang, you have your hand raised.
Yeah, I agree with what Dr. Zhu has said. I do want to elaborate a little bit more regarding the experience with inborn errors of metabolism. We have seen two very good, nice QSP examples today for enzyme replacement therapy. We had Dr. Zeff's presentation in session 2 for ASMD, and also Dr. Gadkar's presentation in session 3 for MPS II. Actually, Dr. Reed's presentation in session 1 also touched a QSP model for MOCD deficiency. So yeah, we can learn something from those examples. So disease treated by ERT, for example, have very well established pathophysiology, which is due to a single enzyme deficiency. ERT has very clear mechanism of action, the biological pathway, and the PD biomarkers for ERTs are usually very well defined and characterized in the clinical trial. So more interestingly, ERTs for like lysosomal storage disorders have very specific, well-defined target site, which is lysosome. So also because of that, we often do not actually see exposure response based on plasma concentrations. So that's why, you know, when we have the QSP model where we can look at the information from tissue, cellular, and subcellular, even molecular, those make us very excited, and they do provide lots of information we otherwise will not be able to see. Yeah, thank you. Just want to share some of my review experience based on those models.
Thank you. That's very helpful. And maybe I don't see any questions coming from the chat, so I'll indulge one of my interests for if you'll indulge me. And this will be to first Dr. Boussard and Dr. Ann. So one thing that I'm quite interested in is, you know, we have in rare diseases, we may have a few patients where we have a lot of deep phenotyping, right? So we have a lot of really deep data on a few patients, and then we may have sparse data on many other patients, right? So this is where I see a huge value in the hybrid approach of mechanistic modeling to fill in the gaps using the data-driven approaches where we have that rich data set. So perhaps Dr. Boussard, you could comment on that.
Yeah, that's a great example, and that's something we're actually looking right now in our prostate cancer models, where, you know, we have patients come in, they come back, tumor grows, we're trying to figure out what happens in between and how we can build that, you know, learn from the mechanistic models that we're seeing in other, well, for us, we're looking in mouse models, and so we're really can leverage that information, and we're developing ensemble models so we can look at the trajectories that we see in these mechanistic models and then see how well they can fit to our human data. It's challenging because we're laying this over, and this is some work. I'm actually I'm getting results on this tomorrow, so it's really interesting. But I think that's a huge opportunity, right? We need to fill in these gaps where in the real world, you know, patients are on vacation, patients are in remission, patients are having these different schedules that don't necessarily fit to our standard randomized controlled trial, where everything is very protocol. People are coming in, they're getting specific treatments. That's not the way it works in our real world environment. And so we need to really think about how we can leverage these different types of models to fill in these gaps and still be very accurate in what we're predicting and where we're seeing like the progression of disease or move forward. So I think it's a great question and really a nice topic to think about more.
Any other comments on that? I do see we have some questions in the chat now. Dr. An?
Yeah, I mean, as I'm finding myself, I agree with Dr. Hernandez-Boussard on this. I mean, I think the fact of the matter is that, you know, an approach, and it's in the chat, there is a appeal to having a mechanistic hypothesis that represents a target that you can then falsify or refine based on new data that comes up, right? Because if you just make statistical models or if you just make machine learning models, those things, you don't know what's actually in them, right? We want to be able to utilize the knowledge that we have. So on one hand, it seems like in the rare disease community, there are certain disease processes for which there's a great deal of mechanistic understanding of what's actually happening. You just don't have a lot of examples of that to correlate to in the real world, which means that a population-based extraction of mechanism is not likely. Conversely, as you move towards the personalization of therapies for even more common diseases like breast cancer, sepsis, et cetera, right, that same process is going to happen because your statistical tools cannot sufficiently parse between all the different heterogeneous configurations that are present in what is otherwise described as a common disease process, right? So that's the basis of this idea that as you move towards personalized medicine, you're actually moving towards a paradigm where everyone is their own, control.
And Dr. Schutz, do you have a follow-up? I know the FDA has been quite interested in some of the machine learning, artificial intelligence. So do you have any comments on this particular topic?
Sure. I think both artificial intelligence modeling and also QSP modeling actually provides the capability for us to take a deep dive into combine into the patient characteristics and try to link individual patients' characteristics into a certain patient response or biomarker changes, and then give us the insights about how this heterogeneous genetic among the patient population may affect our capability to assess those patients and may affect potential future drug development, and also may affect the future trial design. So understanding this would be very beneficial to modernize our clinical trial and drug development in the future. So we actually really encourage we as a community to work together using all the possible tools handy and possible to really address those issues with the final goal, of course, is to really improve our patient care and improve drug development in the long run.
Dr. An, did you have a follow-on?
Sorry, I keep raising my hand, but I can't let AI comments go by without my comment on that, which is that in most of the data that we're dealing with in terms of multidimensional whatever, right, the number of features versus the number of sources of samples is vastly too large to have anything that is actually trustworthy, because you're going to get an answer because the neural network will find an answer, but whether or not that answer is extrapolatable beyond the data set that you have is very much in question and is an ubiquitous problem in the AI and ML community. So then that leads to the question of synthetic data, right, which is an important aspect in almost all applications of AI and ML in other domains. And the danger here is that if you use a fixed equation-based model to represent that synthetic data, your neural network will just merely recapitulate that particular function, right? So you just got to be very, very careful about what the extrapolation is going to be and what the expectation is from these types of approaches. Because as opposed to standard statistical regression tools, right, you're going to get a good fit. You just don't think that good fit is just not going to be applicable the minute you apply it to a data set that is even off just a little bit. So I think we need to be very cautious about what sorts of reliability we have from let's call them neural network, I'll just say neural network approaches towards integrating, trying to provide insight into high dimensional data sets with relatively sparse sample sources.
Dr. Xu?
Yes, you wanted me to continue a little bit. I think, Dr. Nan, I agree with you that each methodology has its pros and cons, and then the capability of using the model or applying that in reality, it really depends on how reliable the results can be. That goes to the next question is that how we can validate the model. Ideally, we want to do that with different sources of information and put it into a larger scale of data, actually to see how the performance is. I think those are probably general principles or best practice we wanted to follow in order to really move this modeling field forward. And also within novel tools, we needed to really get the sufficient ways to validate it and to ensure the results and conclusions are reliable. I think those are great points. Thank you.
And I think on that point, Dr. Xu, that was a very great way to end the panel discussion. We are at the top of the hour. So I'd like to thank you all for a very lively, insightful discussion. And at this point, I will hand it back to Dr. Bai, who will be closing out the session. Thank you.
I want to thank Dr. Musante for a wonderful roundtable discussion. And I would like to share my screen. I want to thank our esteemed speakers, panelists, moderators, and the audience for taking your time to participate in this workshop. Today, we have covered the need in rare disease that QSP may be able to address. We also have covered successful cases of QSP model in rare diseases, and we have touched upon future technologies and how we can build, utilize those technologies to build useful QSP model in rare disease to inform rare disease drug development. And I want to congratulate you on helping us draft a very informative map and forward. And I would like to mention that myself, I suffer from postpartum syndrome, and I see my physical ability decline every day. And the doctor told me there's no treatment for it. You just have to not to have too much physical exertions, but you have to do proper exercise. So this workshop means so much to me, and I would like to say thank you. And I want to leave you with this quote from William Blake. What is now proved was once only imagined. And I strongly believe that we will get there to get many, many more effective and safe treatment to patients who suffer rare diseases utilizing computational methods. And I hope that we can continue our scientific exchanges and collaboration. And thank you so much. And I wish you a wonderful rest of the week and rest of the year. Thank you. Bye-bye.